Infective endocarditis, understanding bacterial heart valve infections. Infective endocarditis is a serious cardiac infection affecting the heart's inner lining and valves. This condition requires prompt recognition and treatment to prevent life-threatening complications. Infective endocarditis represents a serious and potentially life-threatening infection of the heart's inner lining, known as the endocardium. Most commonly, this infection targets the heart's valves, which are responsible for maintaining unidirectional blood flow throughout the cardiac chambers. The condition develops when harmful microorganisms, typically bacteria but occasionally fungi, enter the bloodstream and establish themselves on the valve surfaces. Once these pathogens colonize the endocardial tissue, they multiply and form vegetations, collections of infected material composed of bacteria, fibrin, and platelets. These vegetations can cause significant damage to valve structure and function, potentially leading to severe cardiac dysfunction. The development of infective endocarditis follows natural heart valves and prosthetic valves that involve both microbial factors and host characteristics. Microorganisms access the bloodstream through various routes, including poor dental hygiene, intravenous drug use, invasive medical procedures, or wounds. Once circulating in the blood, bacteria encounter the heart's endocardial surface, where they can adhere more readily if the tissue has been previously damaged. Pre-existing heart conditions such as valve abnormalities, congenital heart disease, or recent valve surgery create an environment particularly susceptible to bacterial colonization. The adherent bacteria secrete substances that help them evade the immune system while simultaneously damaging surrounding tissue. Over time, the infection triggers an inflammatory response characterized by the accumulation of immune cells around the infected heart valves or previous valve replacement tissue destruction and the enlargement of bacterial vegetations, particularly complex structural abnormalities. Previous history of endocarditis, manifestations and symptoms. Intravenous drug of infective endocarditis varies considerably among patients, ranging from subtle symptoms to acute, fulminant disease. Fever represents one of the most common early signs, often accompanied by malaise and generalized fatigue that progresses as the infection advances. Patients frequently report night sweats and a sensation of overall weakness that interferes with daily activities. A new or changing heart murmur detected during physical examination provides crucial diagnostic clues, resulting from valve damage and regurgitation. Petechiae, small red or purple spots, may appear on the skin, nail beds, and mucous membranes as a result of septic emboli lodging in small vessels. Joint and muscle pain can occur without obvious inflammation or swelling. Some individuals present with neurological symptoms including headaches or focal neurological deficits when infected material travels to the brain. Approaches and testing. The gradual nature of diagnosing infective endocarditis requires a combination of clinical assessment, delaying appropriate laboratory evaluation, and imaging studies to establish definitive diagnosis. Blood cultures remain the gold standard, as identifying the causative organism through laboratory culture allows for targeted antibiotic therapy. Multiple blood samples should be obtained before initiating antibiotics to maximize the likelihood of isolating the pathogenic organism. Echocardiography, particularly transesophageal echocardiography, provides detailed visualization of valve vegetations, structural damage, and paravalvular abscesses. Complete blood count often reveals elevated white blood cells and mild anemia reflecting the chronic inflammatory nature of the infection. Inflammatory markers such as C-reactive protein and erythrocyte sedimentation rate are typically elevated. Electrocardiographic complications may be observed if the infection extends to failure from progressive valve destruction. The modified Duke criteria provide a systematic approach to the brain causing by weighing major and minor clinical, laboratory, kidney damage from immune complex depositions or septic emboli, antimicrobial or treatment endocarditis from septic emboli. Treatment of infective endocarditis centers on prolonged antimicrobial therapy with selection based on organism identification and susceptibility testing. Empiric therapy typically begins with broad-spectrum antibiotics while awaiting culture results, generally consisting of vancomycin combined with gentamicin to cover potential gram-positive and gram-negative organisms. Once the specific pathogen is identified, therapy is narrowed to the most appropriate agent or combination with the best efficacy and safety profile. Treatment duration typically extends 4 to 6 weeks depending on organism type, valve location, and prosthetic versus native valve involvement. Intravenous administration is necessary to achieve adequate concentrations at the infection site. Monitoring of antibiotic levels, renal function, and surgical intervention considerations. Management. While antimicrobial therapy forms the cornerstone of deterioration, surgical intervention becomes necessary due to immune-mediated clinical scenarios where medical management alone which does not necessarily indicate treatment failure. Indications for surgery include significant valve dysfunction causing hemodynamic compromise or progressive heart failure, large vegetations at high risk for systemic embolization, prosthetic valve infection, paravalvular abscess formation, or failure to achieve infection control after appropriate antimicrobial therapy. Surgical timing represents a critical consideration, with early intervention potentially beneficial in preventing further complications but requiring careful assessment of operative risk. Valve repair or replacement during surgery addresses structural damage sustained during infection. The decision to operate must balance the urgency of the cardiac condition against the risks associated with undergoing surgery before dental procedures for high-risk patients. Outcomes improve when surgical intervention is performed at optimal timing within the clinical course of the disease before any invasive procedure and long-term outcomes. Avoidance of intravenous drug use and infective endocarditis has improved substantially with modern diagnostic techniques and antimicrobial therapy, yet mortality remains significant, particularly in patients with delayed diagnosis or severe complications. Short-term mortality varies between 5 and 20% depending on organism virulence, extent of cardiac involvement, and patient factors such as age and comorbidities. Native valve endocarditis generally carries better prognosis than prosthetic valve infection. Patients who require surgical intervention often experience excellent outcomes when operated upon at appropriate timing. Long-term sequelae frequently include residual valve dysfunction requiring follow-up monitoring or eventual replacement, persistent cardiac arrhythmias, and in some cases, chronic heart failure requiring ongoing management. Key takeaways for patients and clinicians can occur in previously affected endocarditis represents a medical emergency requiring high clinical suspicion for early diagnosis. Regular cardiac evaluation following treatment helps identify complications early and guides decisions regarding valve repair or replacement should raise concern in both primary care and acute care settings. Blood cultures must be obtained before antibiotics are administered to maximize diagnostic yield. Modern echocardiography provides essential information regarding valve involvement and structural complications. Prolonged intravenous antimicrobial therapy tailored to organism susceptibility offers the best chance for cure, though surgical intervention may be necessary in selected cases. Prevention through appropriate prophylaxis in high-risk populations and awareness of endocarditis risk factors can substantially reduce disease incidence. Close follow-up after treatment completion ensures early detection of complications and guides article visit regarding valve function and need for intervention. Like and subscribe for more evidence-based medical content. Endocarditis remains essential for optimizing outcomes in this serious cardiac condition.